So thank you very much for the kind introduction to participate in this seminar. I will talk about patient safety. As you know, patient safety has become quite a lot of attention in the near past, and it's defined by identification and prevention of avoidable harm that is caused by medical care. Now, anesthesiologists has been at the forefront of this movement because they caused a lot of harm, at least in the past. As you see here on this cartoon, Beecher and Todd came up with the first big study looking into anesthesia-related deaths. And they concluded that there was a number of 64 patients that died from when undergoing anesthesia. This number is now down to about 1, although we have the difficulty to differentiate anesthesia-related deaths from situations where anesthesia contributed to deaths. Now, it does not come to a surprise that the first case report on anesthesia-related death concerned a young girl. This child died 2 minutes after the start of a chloroform anesthesia. And John Snow came up with this case report just about 2 years after chloroform was introduced. And interestingly, in his discussion, he already discussed whether that was drug associated or whether it was just a human error. He concluded that it was a toxicity, and then consequently developed a chloroform inhaler in order to come up with a better administration tool. Now, the risk in children undergoing anesthesia compared with adults is higher. There are, however, no large-scale studies. The most contemporary dates that we have come from the Children's Hospital of Philadelphia. They concluded that the number is indeed also today increased compared with the situation in adults. That is due to various physiologic differences in children that increase the risk. Now, what are the reasons for a lack of improvement in patient safety in anesthesia? Arthur Keats, already 30 years ago, identified 4 major points. That's first, the lack of scientific research. And that holds true in pediatric anesthesia, no doubt. Anesthesia practitioners are primarily practitioners and not scientists. Then, interestingly, he also identified the lack of advances in airway management. That's certainly no longer the case in adults today, but still holds true in children. And then he also addressed that changes were adapted without any proof of benefit. For example, the use of pulmonary artery catheter monitoring. And on the other hand, changes that needed to be adapted were not adapted despite proof of benefit. For example, reallocation of human resources. Therefore, the aim and the structure of my presentation is to describe the actual activities that we have in our department here in Basel. So we are engaged in some research related, as already mentioned, to the mechanical ventilation. This is a project in collaboration with the Swiss Federal Institute of Technology, Zurich, supported by the Botner Research Center of Child Health. Then I will have some notes on airway device development, where we've been involved in the past, and will conclude with some information about the reallocation of human resources in pediatric anesthesia. Now, mechanical ventilation is certainly a cornerstone of care in anesthesia and intensive care. It's applied to newborns or prematurely born to adults, and it's no doubt an invasive treatment that may cause harm Therefore, we need a control and we need a monitoring. That is really essential. Now, the equipment that is used to do this are flow sensors and pressure transducers. Now, really, and as you can see here, mechanical ventilation is usually provided by a ventilator. Then we have a tubing connection. The Y piece is connected to the endotracheal tube. Usually we measure the pressures at the ventilator, and sometimes some devices use the Y piece. And as you will see in our research, we have a reference pressure that's down in the trachea. With these equipment, with the flow sensor, the pressure transducer, we have certain figures that we can use to address pressure, flow, and tidal volume. Now, as mentioned before, the ventilator and the tubing is connected to the patient using an endotracheal tube. Usually, as mentioned already, we measure the pressure up in the airway. But always, when you use an endotracheal tube, you will have a pressure drop. That's variable, and it may be very substantial. And very important, when you use the calculations, looking at the performance of the lung, that's compliance and resistance. When you use the airway pressure, you always have a combined measurement of the compliance in the patient, essentially the chest wall and the lung, and also the equipment, the tubing system. And regarding the resistance, you have the resistance of the patient's airways, and in addition, the endotracheal tube. So the pressure change is very variable, depends on the geometric characteristics of the endotracheal tube, and also depends on ventilator settings, as I will show later on. And very important, these effects are not constant. Otherwise, you would have just the possibility to come up with an estimated pressure in the trachea, but that's hampered by the fact that within the tube, you may have a laminar or a turbulent flow. And as soon as you have a turbulent flow, the resistance increases considerably. So in the end, the pressure drop is influenced by lung mechanics also, and mechanical properties of the artificial airway. And the deviation that you may expect is increased when using small-sized tubes and high respiratory rates, as it is the case in pediatric patients. Now, there have been various approaches to defeat this endotracheal tube-related impact. Almost 30 years ago, the group from Gutmann from Freiburg, Germany, elaborated ways how they could estimate continuously the pressure in the trachea. However, the effects of individual endotracheal tube characteristics and time-related conformational changes like kinking or the partial tube or complete tube obstruction were not taken into account. And this automatic tube compensation is available in many ventilators nowadays, but in the end of limited clinical importance. Another way to get direct airway pressure measurements includes one way how you could do it, and that was done in a number of experiments, is just to use a pressure, a suction catheter or a pressure line down the endotracheal tube. However, this is prone to that misplacement and catheter obstruction, and most important, you can't use it, for example, in the intensive care setting because it disturbs the clinical routine, such as suctioning. Nowadays, we have the possibility with micro pressure sensors. The two that I show you here are the IntraSense and a Bosch sensor. You see, they are really small, and they can be attached using an add-on device, how we call it, to the distal part of the endotracheal tube. As you can see here, with the very small IntraSense pressure, you could even use the lead and drain it up through an instillation channel that's available in some specialized tubes. So basically, you have the technical possibility to bring a pressure sensor to the tip of the endotracheal tube. Now, using the Bosch sensor, we came up with a number of experiments, and we tested the influence of the compliance on the pressure course in the trachea. The setting was a ventilator connected with a tubing system, then the endotracheal tube, and that was introduced into an artificial trachea that was connected to a sophisticated lung simulator. Now, I will show you the traces that we can find depending on the compliance. Compliance of 10 translates to a very stiff lung, and you see the green line is the tracheal pressure. That's almost identical to the one that's measured in the ventilator and the Y-piece. A compliance of 60 translates to a normal lung. Here you see it's quite different. The tracheal pressure has a completely different course from the one that's indicated in the ventilator. And this is even further deviated when you have the condition of a really high compliance, such as situations with patients with emphysema. So in conclusion, you can see we have quite different pressure courses in the trachea, depending on the compliance of the patient with an identical setting of the ventilator. Here. We came up with a series of experiments. Here you see the 3D plot of, on the upper side, we have the tracheal peak tracheal pressures that were achieved depending on compliance and depending on the setting of the ventilator. You may see that we have quite substantial differences in the peak pressure that's measured in the ventilator compared with the trachea. And also the end expiratory pressure might be quite different in some conditions. We examined also the effect of small tubes, simulating the pediatric condition. Here you have again the trace of a normal lung using an adult tube. This is the course using a 3.5 tube, and when you have a 3.5 size tube with an additional partial obstruction, it's even more deviating. So you can conclude from this that we might profit, especially in pediatrics, from the use of this kind of measurement. To sum up, we have all the traces that we could observe. That's the big tube with a low compliance, normal compliance, again, a big tube, adult tube with a high compliance, and then the pediatric sized tube without obstruction and pediatric size with a high compliance and secretions. So you get quite additional information from measuring tracheal pressure that you can't derive from the ventilator. Now, another thing is, I mentioned it's monitoring and also controlling the ventilator. So as mentioned, our project is related to the COVID pandemic. So we, as part of this grant, we assessed low-cost ventilators, and one of these ventilators is the so-called COVent. You see you see it depicted here. It's a pressure-controlled ventilator with that works with a turbine, and you see the control and measurements are done by a flow sensor and pressure sensor that's located at the end of the tubing system. Now, when you, in a in vitro experiment, again, using the same test chest, you can see when you use the controlling, the existing controlling of the COVent, you achieve the blue line. So it's somewhat the values that we would like to have. And this is certainly improved when we use the tracheal pressure to control this ventilator. There's still a long way. If you develop medical devices, you need to bring them into medical practice. And if you want to introduce a medical device, you have to comply with medical device regulation. That's a regulation that's come up by the EU, that's been taken over by Switzerland, that concerns the clinical investigation and also the sale of medical devices. And also of importance, it also asked for recertification of existing medical treatment tools. And as you can see, Swissmedic came up with a note, a guidance document that announces substantial modifications to clinical investigations of medical devices, making the development of medical devices more complex. Now, usually there are already really a number of burdens when you want to develop a device, but there are some additional or exacerbated burdens when you want to come up with a pediatric device. You see, estimate the commercial value of interventions. Often we have only a limited number of applications. Then on the other hand, this kind of passing these regulations is very costly, and it's even more costly when it's applied in children. And all of this is done in rise investment capital is usually done in a startup culture. So you want to introduce a device and make as much money as you can. And usually in the context of medical care in children, this is not really easily achievable. I want to show you how the experience that we encountered with coming up with, trying to come up in one case and coming up with one medical device. So Franz Frey, the former chief here of Paediatric Anesthesia in Basel, he just modified a regular face mask by taking off the connector of the face mask and replaced it with a silicone membrane that was distendable and had the possibility to bring the fiber optic bronchoscope through the membrane. Even you could bring in an endotracheal tube, And that allows you to administer 100% of oxygen. You can apply CPAP, or you may even ventilate the patient. And this device was produced by a German company. Once this device was available, we came up with a number of scientific evaluations showing that there is indeed a value. And good news, also this device passed now the re-evaluation that was needed because of this new MDR. Now with another device, we had more difficulties. Respectively, we didn't achieve our goal. Here you have a condition in children when they undergo MRI, then they often need a sedation. Sedation implies that you may have an obstruction of your airway and you have effects on the regulation of the breathing. That's monitored with the use of capnography, and we usually use a modified nasal prong that allows you to come up with the administration of oxygen on one side and the CO2 monitoring on the other. However, if you have severe obstruction, you may need a so-called Gödel airway device where you could overcome the obstruction. However, this device does not have a CO2 or O2 probe. So combining two things, bringing a capnography tube probe to the tip of this Gödel airway device, and also administering oxygen at the proximal end would allow you to overcome this restriction of the Gödel. And in a comprehensive evaluation, we could really show that under all conditions, the monitoring using this Gödel device was more accurate compared with the one that we usually use in our children's. However, the same company, based on economic rationales, decided not to realize this commercial production and the introduction in clinical practice really based on economic rationales. So we might need to have support to get essential pediatric tools realized in the real life. Now, the last point is referred to the allocation of human resources. In order to have a good treatment in children, you can't ignore the human factor. And in Switzerland, with really a lot of resources, you hardly have any restrictions for prestigious treatments. For example, in Switzerland, we have 4 centers where cardiac surgery is done. So in the end, we have too many institutions, and also when taking into perspective our situation, too many anesthesiologists who treat a low number of patients. That was the reason that the Swiss Paediatric Anaesthesia Project 2030 was initiated, and the goal was to come up with a guideline that allocates specific patients to qualified institutions with qualified personnel. Now, again, I want to show you. Yeah, no. These are the results of the so-called Nectarine study. There's a huge European study, observation study, looking into complications and the course in prematurely born children and neonates. And as you can see on this graph, the risk of children undergoing anesthesia with low age is really tremendously higher compared with even with neonates, where we know that they are also susceptible to harm compared with older children. This fact led to the conclusion that we will need specialized pediatric referral centers in Switzerland, where the neonates are taken care of by the anesthesiologists. And then other institutions, such as large cantonal hospitals, they should abstain from taking care of these kind of patients. You see other conditions like medical conditions, surgery, and the overall assessment using the ASA score is used to allocate the specific patient to a specific organization. And this was done then in process which was with Society of Paediatric Anaesthesia, and we could even convince the Swiss Society of Anesthesiology and Perioperative Medicine, so the entire organization regarding anesthesia in Switzerland, to support this guideline. And interestingly, now this has implemented in Switzerland for the first time by the health department of Zurich. They came up with the requirement that before you want to do surgery on a specific child, you need to have a qualified an anesthesia service that qualifies to get to deliver an anesthesia to this specific patient. And again, you have only the specialized center is allowed to treat all patients. Now, I'm at the end of my presentation and would like to conclude that I hope I was could convince you that we deserve ongoing efforts for refinements of scientific validation. And I could show you that the development of medical devices has become even more demanding, and in the end still you may lack the funding that you need to get your device produced in the real medical world. And last but not least, also the political debate is mandatory to enforce the needs for children. If we don't do it, no one will do it. So I would like to thank the Botner Research Center for Child Health for their support. And without the tremendous contributions from Mark Zander, Marianne Schmid-Danners, and Marco Mebold from Zurich, and Nikola Stankovic and Jörg Hammer from Basel, this work would not have been possible. So thank you very much.